Hello, my name is Janet and I'm a publisher with Elsevier. Medicine Journal is a collection of current reviews for internal medicine training exam revision, as well as for continuing professional development. Medicine's editorial board comprises of subject matter experts across all subspecialties of clinical internal medicine. As we publish each chapter in the journal, our chairman, Albert Ferro, will be interviewing the relevant board member and chatting to them about their specialty. We hope you enjoy them. To find out more about Medicine Journal, including how to subscribe, please visit www.medicinejournal.co.uk. You can also follow us on Twitter using the handle @MedicineUK1.
Hello, and welcome to the latest video interview for the journal Medicine. I'm Albert Ferro. I'm a professor of clinical pharmacology at King's College London and chairman of the editorial board of Medicine. I'm delighted to be joined today by Dr Tony Lockett. And the reason he's joining me is that he helped put together the latest issue of Medicine, which is the June 2025 issue, which is all around statistics in medicine. So welcome to you, Tony.
Thank you, Albert, for the opportunity to talk today.
Delighted to have you, and we're old colleagues, so it's nice to catch up with you. But maybe we could start off just by you telling us a bit about yourself and your background and what you do.
My background is I trained in medicine at University of Newcastle in the days of leeches, I think. I then specialised in tropical medicine and spent some time in sub-Saharan Africa before coming back to the UK and joining the pharmaceutical industry, where I was until, well, in a way I still am. I was with big pharma, small pharma, minuscule pharma, regulators, and now I basically spread my time across three main activities. Firstly, I'm senior lecturer in pharmaceutical medicine at King's, where I work particularly in the area of rare diseases and clinical trial design and research methodology. My second activity, I am a medical ethicist working with HRA, but also other academic and industry partners. I'm particularly interested in the ethics of rare disease trial design and the role of lived experience and patient identity. And finally, I'm working particularly in the area of rare disease, neurodegeneration, motor neuron disease, frontotemporal dementia, with a spin-out of Durham University called Nevrogenics. And we are about to start our clinical trials later this year in motor neuron disease and frontotemporal dementia. So my focus is very much on design of clinical trials, ethics of clinical trials, and rare disease clinical trials in particular.
Thanks, Tony. And of course, I know you from King's, from the pharmaceutical medicine course where we teach together.
Yes.
And a lot of what you described are the kinds of things that we might sort of touch on today. Things around clinical trial design and rare diseases and so on. And just to say for the viewers of this that we won't be able to discuss in detail all of the things that are in the June issue. We'll touch on one or two aspects, but for fuller details, do please go to that issue where you'll find lots to read about. But maybe we could start off, Tony, talking about clinical trials. And of course, you know, we all think of the RCT, the randomized controlled trial, as the gold standard and the be-all and end-all. And we've had some discussions about this, that sometimes it is and sometimes it isn't. Sometimes it's not necessarily the most appropriate. Could you just maybe tell us your views about the place of RCTs and whether other study types might sometimes be appropriate?
There is little doubt that a well-designed, well-executed, randomized controlled clinical trial does provide the best evidence that we have of the benefit and safety of new and existing medical interventions. That is without doubt. However, the trials that I see in relation to the work I do in medical ethics and the work I do with the rare disease community indicates that RCT trials are in a bit of a crisis at the moment. I see probably 5, 6 RCTs go across my desk every week in my role as chairman of one of the ethics committees. And, the majority of these are major amendments, critical amendments to clinical trials. Some recent work that's coming out of the McKinsey group suggests that up to 60% of RCTs require adjustment in their endpoints or in their statistical methodology during the conduct of the trial. And 80 to 90% of RCTs currently do not complete or are significantly delayed. And there are 2 reasons for this that we try and discuss in the articles. The first is that RCTs are often poorly designed. That because the emphasis is to produce an RCT because it's considered to be best evidence, I think sometimes investigators shoehorn themselves into an RCT when really one isn't appropriate. And this is particularly the case in rare disease and life-threatening diseases or life-limiting disorders, where patient numbers are low, patient life expectancy is low. And so you end up, looking at things like placebo-controlled trials, that the part of the RCT structure, when reality is that they're not appropriate, that there are other clinical trial designs, like we discussed in the articles, Bayesian designs, adaptive trials, which still have elements of RCT, but are more suited to doing it. So the first reason, as I say, is there are circumstances where RCTs, should not or should be reconsidered. The second reason that I mentioned is poorly designed trials. And as I said, a lot of the time, a lot of the reviews or a lot of amendments that I end up reviewing are changes in the endpoint. And I don't think we spend enough time really considering the endpoints, the relevance of the endpoints to the feasibility of the trial. I don't see, I see a lot of trials which, start out with a particular clinical endpoint. And, my work, as you know, is in motor neurone disease, and start out with a clinical-based endpoint or an endpoint based on survivability. And the investigators and the regulators and indeed the patients, they are very important in all of this. They simply can't recruit, or they find that the survival rates are radically different to what they've assumed because they haven't done proper, robust meta-analyses and literature and synthetic reviews to enable it to work. So I think RCTs, as we've said, are still the gold standard, but they need to be well-designed RCTs, and simply having an RCT is not enough. It needs to be based on firm evidence. And secondly, you know, there are circumstances where you can get as much, if not more reliable information from things like a real world trial, an observational trial, either as a run into designing a better RCT or in fact providing the pivotal evidence. Regulators are changing also. I think, you know, I was discussing with a regulator last year in motor neuron disease, and clinical endpoints and survivability are not always the best endpoints to choose. So we have three issues, as we've said. The first is suitability of the trial. You know, can we really do an RCT? Will it give us the information? The design of the RCT in relation to things such as survival and endpoints. And finally, as I said, regulators are changing their position, particularly with the design of biomarker-driven trials in this area, in the areas I work in, particularly rare and life-limiting disorder.
So, as you say, the rare diseases space is quite a problematic one in terms of the things you've mentioned, the feasibility, the suitability. Are there any examples where you can give us a feel of the sort of trials that you've been involved with, which have been appropriate in rare diseases? Trials
of sort of the Healy trial design, the platform trial that Merrick Kutkovich runs in Boston. That's an example of a well-designed set of trials. It uses biomarkers to make early decisions based on Bayesian analysis to really minimize the length of times that subjects will spend on trial. You know, some trials are designed for a 24-month trial in motor neuron disease. Some of the recent trials that we've seen with metformin and other are designed on 24-month endpoints. These individuals, these sufferers, you know, probably have between 24 and 48 months to live. So a trial in that situation is a death sentence. The Healy trial, designed by Merritt and her colleagues in Boston, is a very good trial design in that aspect. It uses Bayesian methodology to try and minimize the length of time. It uses a pooled control group, so we don't see the high randomization of placebo, and really it is aimed at pulling out, you know, successful compounds as quickly as possible. But we say it is a well-designed trial, but even Merritt herself, you know, is now beginning to wonder about the sorts of agents going into that trial. Product repositioning, for example. Many of the products that she's put through are repositioned products, and you know, there is a need to start looking at not just the condition, but how we design trials for innovative new agents is the problem. But the Merritt trial design, you know, the Healy trial design is a very, very good trial design. but even that is still not fulfilling the need for innovative trial designs in rare and life-limiting disorders.
Let's move on and talk about systematic reviews and meta-analyses, because obviously that is something that uh, viewers of this will come across in their reading. And I just thought it might be useful for the non-initiated to say a word or two about what systematic reviews and meta-analyses are, their pros and cons, and how to read them, how people should interpret these sorts of reviews. So again, I'll be grateful for your views on this.
My own view, Albert, is that meta-analyses, systematic reviews are one of the most underused tools that we have. I think they do, again, similar to the discussion that we've just had about RCTs, they do provide very, very firm evidence of benefit and enable, facilitate decision making, not just around trials, but around, healthcare in general. So the basic principle here is that no two trials, no two evidence sources, no two results are in reality the same. They all, each trial, each experiment, has subtle changes in the patient population, subtle changes in the way it's conducted, which affects the outcome and the statistical variability of the trials. So meta-analyses, synthetic analyses, metasynthesis reviews are a way to try and bring all of that data together. They're a way to try and standardize how we look at the relative risk and the outcomes in an attempt to try and synthesize the evidence that we have. They're by and large computer driven, and I'll come back to that in a second, but they are standardized, they are methodology which enables us to do it, but they're only as good as the data we put into them. They're only as accurate. And I'm a big believer in or a big fan of what's known as metasynthesis rather than pure, simple meta-analysis. And metasynthesis is an extension of systematic review, and we do talk about them in the papers. Because, there's not just the statistical elements that need to be considered. There's the other elements, the almost qualitative data that meta-analysis does not consider. So they are, as I say, I think, a very, very underused tool. I think, again, using the example of some of the trials I've seen in motor neurone disease, looking at repositioned products like metformin, there is a load of data out there which, I've not seen fully evaluated in a meta-analysis to indicate, how this should be used in the trial design, for example. But they are an extremely powerful tool, but they have the disadvantage of discarding the qualitative data. So when you're looking at a meta-analysis, don't just look at, the forest plot or the scattergrams that you see there. Try and see if the authors have very clearly stated their inclusion-exclusion criteria for the meta-analysis. I reviewed one of these for a medical journal last week, and they had something like 1,600 oncology patients in oncology trials in the top, but they only actually analysed 16.
Mm.
and they didn't explain where the other, 1,500 had gone.
Mm.
So look at that, but also look at how the statistics that are being presented is related to the real world evidence, to the qualitative evidence that X, is better than Y. But as I say, I think they're a very, very powerful tool that needs
Mm. Mm.
further evaluation. And it is happening. I mean, with the COVID reviews, we saw the evolution of the Cochrane methodology, the Cochrane Rapid Review, which I think is a major advantage. So it's a work in progress,
Mm.
but let's not think about let's not discard them. Let's really try and integrate them into our trial strategy.
Absolutely. I think a well-designed meta-analysis can be really useful, very powerful, but it does depend on
Yeah.
adequate design and inclusion of the appropriate studies and so on.
Yeah, and also trying to relate those to other bits of evidence.
Mm.
You know,
Mm.
we all have got the frequentist problem,
Yeah.
the one in 20 significance number. But
Yeah.
if that can be backed up by qualitative data using
Yeah.
mixed
Yeah.
method
Yeah.
analysis, much more powerful.
Let's turn now to Mendelian randomization. And I think it's fair to
Mm.
say that there's been a profusion, a huge increase in the number of publications on Mendelian randomization. It's something of a factory, in fact. Um, Again, it's something that viewers may come across. So perhaps you could just explain to us briefly what Mendelian randomization studies are, and where are they useful?
Well, Mendelian randomization studies are exploding, as you said, partially because we've begun to understand the genetic factors that influence response to disease, or response to treatment, rather. So we understand a lot more about personalized medicine and response to, using example again, there are 3 or 4 genes that are known to influence the effects of metformin. So what Mendelian randomization does is it looks at the outcome of people who have the genetics which would predict a positive response against those who have the genetics which would not predict a positive response. And by doing that randomization, you are accounting for a lot of confounding variables, a lot of biases, which could be due to lifestyle, which could be due to disease heterogeneity. So Mendelian randomization, say, takes a genetic response factor and randomizes participants in trials based on that genetic fingerprint. And then by comparing those with the response genes to those without the response genes, you end up getting a picture of benefit and effects. They are, as I say, they are being driven because we have increasing knowledge of response factors to genes. We are benefit from that. However, the statistics of them and their statistical robustness is still open to question. And again, it's the same as an RCT. If you have a very well-designed randomized trial, you get good results. If you have a very rigorous Mendelian designed trial, Mendelian randomized trial, you will get good results. But it really is very, very pivotal. The independence of the genetics from the outcome that you're looking for. And sometimes that's missing. But yeah, they are exploding, and people are very interested in them because of our greater access to genetic information. They're used particularly in diseases, as we said, like neurodegeneration, where we do understand a lot of the response genetics now. And we can randomize on the basis of those response genetics independent of treatment.
I was just going to say, I suppose that the great strength of these studies is that your genetics is determined from birth. And so there's no confounding from, as you say, outcomes or other confounding factors. It's purely down to your genetics, which is a very powerful, powerful thing.
Yes and no. I think, yeah, our genetics is determined from birth, but we are beginning to realize the influence of the epigenome.
Hmm. Yeah, absolutely.
So one of the familial forms of ALS is due to the C79ORF9 mutation. And we've pondered for many years why people with the mutation don't, some do get disease and some don't get disease. And it's the number of replicates plus the epigenetics which determines whether they get disease, not the presence or absence of the gene in itself.
Mm.
So it's an interesting set of issues that, where we've got very clear relationships like the ALDH3 gene, for example, which controls for acetylation, I believe, from memory. Where we've got that, which is a very clearly causal gene, fine. But in conditions like neurodegeneration, where we have fuzzy genetics, I think it can lead to misguided, misaligned results.
As you say, the epigenome and epigenetics is very much an evolving field at the moment, and I think it's going to be increasingly important in years to come. We might just finish off, Tony, with a bit more of a general discussion for the jobbing clinician who wants to know how to read a research article. And I suppose if you work in the university, if you're an academic, you're producing your own research papers, and you'll be much more used to this. But if you're a clinician who's working in the surgery or on the wards, and you come across a research article, you want to know, well, how do you take away the main points of a paper, and how do you critically look at it yourself? That's quite a wide question, I know, but do you have any thoughts on that?
I think one of the problems that we have, Albert, is that we have a plethora of guidance. We have, things like the PRISMA methodology, the CASP critical appraisal methodology, and these are very widely spread and very, pardon me, commonly cited. And I think sometimes clinicians feel overwhelmed as to what they should be doing. I think the critical things for me is who funded the research. Was the research independently funded, or was the research at arm's length from the funders? That can be very hard to determine. But I think it does kind of indicate, the quality of the research. Secondly, was the research registered? And thankfully, increasingly, journals are only publishing, articles where the methodology has been previously registered with things like Prospero or the Joanna Briggs consortium. So if it was registered, if it was peer review protocol, if it's got independence on it, basically transparency on the methodology. You know, I often read papers and you find yourself thinking, what have they done? How did they do that? And then I'm a great, as you probably well aware, philosophically, I'm a pragmatist. And I'm looking for supporting evidence that does this work? Do I actually believe it? Do I actually think that for all of the clever statistics and clever sub-analyses that's being done, do I actually pragmatically think, yeah, that makes sense? But I think, clinicians get drowned almost by the plethora of recommendations for, critical appraisal skills, etc. In reality, my bottom line is, do I believe the results? And then asking myself, why do I believe and why do I not believe?
That sounds like a very sensible and pragmatic approach, as you say, Tony. There can be lots of confusing stuff in there, like complicated statistics that you may not be familiar with and so on. But at the end of the day, you're quite right. Who was funding the research? Was it independent? And does it make sense? Does it fit in with what you know? And if it doesn't fit in, perhaps you need to look for other supporting evidence elsewhere.
Yes, definitely, definitely. And I often may sound a bit glib, but I work a lot with patients. I work a lot with, patient support groups, those with the lived experience. And I know that's a subject of entirety in itself. But I find I could go to give you an example, one of my heads of one of my patient support group, Mark, and I can say to Mark, look, Mark, I've just read this. I give it to him. And he'll come back and he'll say, I don't believe this, or I do believe this.
Hmm.
So often, pragmatism and getting feedback on from patients as to what the meaning of this is actually a very valuable and important tool, because as you say, the number of statistical techniques is growing all of the time. And I sit at FDA and EMA meetings, and I have a PhD in econometrics and econometrical statistics. And you just think, wow, but what does it mean?
Hmm. Indeed, that's a very good note to end on, I think, Tony. And I think we've gone past our time, but it's been fascinating. So thank you ever so much once again for joining me today.
It's a great pleasure, Albert, and always happy to discuss with you or your readers issues that we raise, and never stop learning is my motto.
Absolutely. Goes for us all. Thanks very much, Tony. Bye for now.